Good. And this will be one of the, so that ends kind of the anatomy type stuff. I thought we'd just get through that quickly and ask some interesting points about each of those bits of the anatomy: diaphragm, chest wall, and pulmonary vasculature and the circulation. And then this next syllabus point is describe the neural and chemical control of ventilation via the central and peripheral chemoreceptors and indicate how this is altered by anesthesia and abnormal clinical states. So one of the short answer questions, again, we're trying to make this as exam oriented as possible to get pen on paper and do active learning. So list the physiological factors that increase rest rate and include a brief explanation of the mechanism by which each achieves the increase. So I'll actually give you 5 minutes on this, but first of all, I might ask just a few people, what structure do you think you would use in writing out this answer? When you do write out the answer, I literally just want a structure and a few dot points because I'm only giving you 5 minutes. So there's more of an exercise in structures and how you're gonna write stuff out. So maybe Meg, how do you reckon you'd answer this, Meg? Or what structure would you use?
So I probably would start with kind of the points not to miss, which is to talk about CO2, O2, and pH.
Fantastic. Yeah.
And then I would include, then I would discuss probably response to exercise and response to anesthesia, and then disease states would be my factor, would be after that. Yes. I suppose you could break it down more and think of sort of chemical and neural, but I feel like this is such a big topic that you just have to really hit the, or at least in my mind, I feel like I have to really hit the kind of focus on the points that I can't miss.
Yeah, good.
Otherwise, you could write about it for 2 hours.
Yeah, that's right. And that's a good thing if you can write about it for 2 hours, because that's a lot of knowledge there.
No, I mean, you could write about it. I didn't mean to say I could write about it for 2 hours, but one could.
One could. Hey, Meg, don't be humble. You got this. And so that's exactly right. Now, I definitely think that's a good way of doing it, because this literally asks what are the physiological factors that increase rest rate, and I think giving most of your time for the important factors, CO2, O2, pH, and then other, and then prioritizing those as you find the time you get. I also add in at the very start this kind of just general statement and a sensor. Because literally what this question is asking is just the sensors, but I can always give a bit of a throwaway line about this is, a central control effector type system, and the sensors, which I'm going to talk about mainly, because these are the physiological factors, are this, and this, and then a brief mention of central control and effector. But yeah, let's crack on. So.
Okay, so I broke it down the way that we were talking about. So the first factor that I talked about that increased respiratory rate was the PCO2, so the partial pressure of CO2, not the content of CO2. And the way that it increases respiratory rate is via central and peripheral chemoreceptors. So I talked about central chemoreceptors first because they're responsible for about 70% of the response, even though their response rate is slower than the peripheral chemoreceptors, I believe. So the way that it causes an increased respiratory rate is that the CO2 diffuses across the blood-brain barrier, which under normal circumstances is not permeable to H+ or HCO3 ions. It then, through the action of a carbonic anhydrase, is converted to H2CO3, which dissociates to H+ and CO2. And the H+ acts directly on the central chemoreceptors, which are located in the medulla, where you've got the dorsal and ventral respiratory centers, and that results in an increased respiratory rate. I suppose the effectors in that case are the respiratory muscles, which we would have mentioned in our introduction. One of the important things to know about the CSF, which is where the H+ ions are located, is that it has limited buffering capacity because of its decreased protein concentration relative to plasma. And therefore a small rise in H+ ions results in a large change in, or a large decrease in pH. Okay, so far, happy for me to
that's great.
Peripheral chemoreceptors are responsible for about 30% of the response, but they do act faster. They're located in carotid and aortic bodies and relate to the central controller via the glossopharyngeal and the vagus nerves. The important thing to know about them is that they have an extremely high blood flow rate relative to their mass, which I believe is about 2,000 mil per 100 grams per minute, which is much higher than anything else in the body. And that they sense pH and PCO2, I guess, directly. And pH is a factor in change in respiratory rate, as we've discussed, through both the central and peripheral mechanisms, pretty much the same as we've discussed. Then the next factor was oxygen partial pressure, which I believe is sensed by the carotid and I can never remember. There's carotid and the aortic, and one of them doesn't sense one thing.
And either way, is it peripheral and central, or just peripheral?
I believe it's peripheral, but at critically low levels of oxygen delivery, where you get the CS, like the central ischemic response, which then results in a sympathetic activation. You could then argue that it's central.
Okay, that's an interesting angle to it. So good. I actually don't remember which one it was. Does anyone have an answer to that? If it's carotid and aortic bodies, or just one?
The response to decreased O2?
Yes.
Yeah.
So I think carotid is most important in relation to the response to hypoxemia.
Yes. Yeah.
Keep going.
Yes, thank you.
Well.
That they start firing around 500 millimeters Hg of oxygen, but that there is minimal response. So I drew a little graph, if you can kind of see, that at around 60, sorry, it's going to be backwards, isn't it? That around 50 to 60 millimeters of mercury, there's a sudden dramatic, it almost looks, it's like exponential, but it almost looks linear in terms of increased respiratory rate to hypoxia, which is significant, I suppose, on the top of Mount Everest, or in situations of critical hypoxemia. Yep. And I guess you could argue that there's a stagnant hypoxic response in, say, hemorrhage or critically low blood pressure that can be sensed as well. I then talked, sorry.
Keep going.
Yep. I then talked about that there is a, then I sort of said other factors. So exercise was one that I chose to talk about, which actually you might be able to tell me a little bit about, because I found the resources kind of conflicting in terms of what is the cause of response to increased respiratory rate in exercise.
By the time you're given, because right now you're given a really complete answer. Like when I've looked at all the points of facts that I've got down here for CO2, central, peripheral, O2, peripheral, and then relevance of pH and the effector and the central control, you pretty much hit all those facts. And just to give you perspective now, that first of all, exercise in West, as I remember it, unknown mechanism. So already we're not going to be worried too much.
So,
be good facts.
Yeah. So that there's an increased respiratory rate in response to anticipation of exercise, and no one really knows why. And then respiratory rate increases with, to a point with duration and intensity of exercise. Some people think it's a response of like the muscle spindle or something like that, or the hypothermia that it occurs with exercise. Anxiety results in increased respiratory rate. And then I would go on and talk about anesthesia. The most important factor is that response to hypoxemia and I believe to CO2 is blunted even at extremely low levels of MAC. So it's been recorded even 0.1 levels of MAC, and the significance of that is it should always supply oxygen to people in the recovery room. And then disease state, we talk about COPD and how long-term hypercapnia is buffered by active secretion of bicarbonate into the CSF, and that increased, and then another disease state I talked about was just increased ICP, so which results in abnormal respirations via direct compression of the brainstem during the Cushing response.
Sounds good. So in a short answer question, you've got all these great facts there, and you've got a good structure for it. And let's say, because you're doing well, I'll just now as an examiner, I imagine I'll just have a whole bunch of facts that I know, and I just want to probe that knowledge to, find out more. So how much, like for every millimeter mercury increase in CO2, how does the ventilation increase or change?
Oh, I actually don't know. So increased in millimeter, I'm going to say,
in say liters or mils per minute, how much does it?
Yeah. So I'm going to say what? I'm really bad at estimating as well. So I don't know, say increase CO2. I'm thinking how long does it take to blow off CO2 when I have a patient under anesthesia and I increase their rest rate? Maybe 25 to 50 mils.
It's 2 to 3 liters per minute.
Oh, okay.
This is interesting, right? The body just defends.
Oh, sorry. I was thinking of tidal volume when I turn up on the.
Oh yeah, fair enough. No.
Yeah. Sorry. Yeah.
Per minute, all good. Okay, here's a question. How rapidly if you have a patient apneic, how much does the CO2 rise? How much does the PA CO2 rise every minute?
It'll depend on the basal metabolic rate, won't it? Because I guess like there's that respiratory equation where you put PCO2 is like the volume produced over the volume cleared.
Sure. Let's say on average, let's say. There's this number, this is 4 millimeters mercury PaCO2 per minute.
Okay.
And if you ever go to a thoracics list or a list where you have to give an apneic time, I recommend you guys check the end-tidal CO2 or PaCO2 and time it, and it's actually surprisingly accurate.
So you said it was 4 millimeters of CO2 per
every apnea.
For every minute, did you say?
For every minute of time. It's not exactly that, so I think it's maybe slower at the start, faster in the middle, but on average it's about 4 millimeters mercury. Remember, I had a 20-minute apnea time on one thoracics case, and it was literally 20 times 4 above that we went to. It was the number was exactly right. That's my that's my n equals 1 of doing a long apnea time. Good. And everything was fine with that. So if I had to mention the central system, I would really just mention the medullary respiratory center, dorsal respiratory group, ventral respiratory group, which is in part of the reticular formation. If I needed to mention other parts like the apneustic center or the pneumotaxic center, it'd be just very briefly. Like it's only a couple of lines in West. It's not that important to mention.
Yeah.
And the cortex, obviously, because you can do this voluntarily as well. Excellent. Which is faster? The peripheral response or the central, or the PaO2 response or the CO2 response?
So were you asking which is faster in terms of the central or the peripheral, or which is faster in terms of the CO2 versus the O2?
CO2 versus O2.
I think the response to CO2 is faster.
I've got here the PaO2 is a very fast response, but it's less important. So it may not have the amount of gain in that system, but it is still a very fast response. Good. So here are just all the various facts about the central controller and the effectors, which is, again, very easy to put down, just correct facts about this. And then I've just put in here, what are the factors that increase and decrease? Actually, here's one. So if you were to draw a diagram for CO2 and ventilation, or how ventilation increases with rising CO2, what would that look like? Can everyone just draw the diagram? Hey, Catherine, I'll get you to describe this diagram here. I've got that. I think this is the one from West's.
So this is your alveolar PCO2 versus minute ventilation graph. It basically shows that you have a relatively linear increase in your ventilation for any given alveolar PCO2, and you have like increased slope of that curve with like more response if you're also hypoxic compared to if you're not.
And is that hypoxic or hypoxemic?
Hypoxemic, sorry. Yeah, PaO2.
Fantastic. And Meg's already drawn this graph, but Catherine, can you just describe this graph for me again?
So yeah, this is our minute ventilation versus arterial PaO2 graph. Basically shows you have very little response to PaO2 until about 60 millimeters of mercury, and then it rapidly increases your response to ventilation below that.
Fantastic. Now, there's a really good thing that Meg did in her answer, which was, like this question here, it's just asking about, what are list the physiological factors that increase rest rate, including a brief explanation. By this time, when you've written your short answer questions and you look at the examiner's reports, they can be pretty variable in what they want, what they want you to say. So I think a really great percentage play to try and get as many marks, to try and milk as many marks as possible. Every time I think of a question, I just go under anesthesia and under disease states. If you were to mention those things, it could be marks for nothing, really. All you have to do is mention it and make something up that's pretty reasonable. The fact that sometimes the examiners don't want it and sometimes they do, it's not a game for you to play. The game for you to play is just to put as many answers on the boards. For example, if I asked you the effect of opioids on the respiratory system, you say all your pharmacodynamic effects, and then you say these are all worst under anesthesia because it decreases the gain of the system or the response of the system, as well as making the patient more vulnerable in disease states. And suddenly you have clinical context and hopefully more marks as well.
Lahiri, can I just ask about for your CO2 ventilation response graph?
Yes.
Like I've also seen graphs which are drawn actually quite further out to the right and including a period where your ventilation starts decreasing at a certain PCO2, that kind of like CO2 narcosis period. Okay. Would you routinely draw that in your exams, or do you, this certainly seems to be the more common diagram that's drawn?
What would you do?
I think classically the number which I decided on after finding a range was that like around about a CO2 of 80, you can start actually getting a decrease in your ventilation response. So I tend to draw it as, well, actually I'm just holding up to the camera of what I've done, down to the bottom. So sort of between about 30 to 60, you've got your relatively linear section. And then at around about a PCO2 of 80, you can get that hypercapnic decline that can be associated with hyperventilation.
I've actually never seen that graph. So
I think I self-constructed it in my original notes, so I'm not surprised you haven't seen it.
Okay. And so I would almost draw this graph in its pure form and then risk it with going, this theoretically could happen. But yeah, no, that sounds reasonable. Have you guys read any papers about the curve flattening? I'm sure there is one out there. I just haven't seen it, and nuns. I don't think nuns or Wests shows a graph of that. But
I think at the time I remember trying to look like what was the CO2 at which CO2 narco. I think like the term CO2 narcosis is occasionally like thrown around.
Yes.
But the actual value at which that occurs, I found things ranging between like 60 and 160 millimeters of mercury.
Yeah. I imagine by that time it's very hard to have a pure CO2 narcosis pathology. Like there's always other stuff going on, so it'd be very hard to show that. But yeah, no, I think that's reasonable what you've done. Make it a side note rather than the big part of it. Catherine, what do you make of this other graph?
So this is sort of the opposite of the one on the previous page. This is our ventilation and PaO2 for different PCO2s. And it basically shows that, similar to the other one, for our ventilatory response to hypoxemia is increased. The response is increased with higher PCO2 compared to with lower or normal. Yeah,
sounds good. Good. So that's respiratory control. That's essentially respiratory control.
Sorry, I was just wondering if I could, Matt, just to Mason's point in relation to that graph. Hey, I've just got Chambers and Wang here, but they've actually got that graph in there too, where it tapers off when you've got that high PaCO2.
Oh, excellent. Which
thanks for reading this.
Yeah, no worries. Yeah, Chambers. Control
What's the magic number that they've plugged for?
It's in kilopascals, so you'll have to convert. But it looks like in a normal ventilatory response about 10, just above 10 kPa.
What is the millionth mercury of that?
Oh, it's roughly 75 or something.
Yeah, good.
Yeah, I just googled it. It's 75.
Yeah.
Okay, good. We never used Chambers when I was going through it. It was always Nuns, West, and Lang that some people had. Is Chambers a relatively new book on? Is it part of the syllabus or?
Yeah, it's part one of the first part recommended texts. It's just a good sort of overall, kind of like Power and Chem, but just a little bit more detail in certain areas.
Good.